Perfect. So, hello to everybody. Before we start, some housekeeping rules. So I would like everybody except the presenters to mute their speaker, sort of the microphone. Sorry. So you can so we don't get noise in the background. Thank you very much. So first, thank you very much for everybody to connect today to our first webinar that we are doing the WhatsApp team in MSF Spain. So thank you, Karibu to everybody. First, I would like to introduce myself. So I'm Maite Guardiola, one of the two WhatsApp referent at headquarters, based and connected here in Nairobi, and also connected and presenting will be Paul Jauer, based and connected from Barcelona.
Hello, everybody. Nice to see so many people here. So, as Naite said, I'm Paul from doing the technical referent for water and sanitation based in Barcelona. Over to you, Maite.
So the objective of this meeting is twofold. First of all, like at the end of this presentation, we expect that you know which is the strategy of response of MSF in cholera outbreaks. And secondly, that you end up all being familiar with the main differences that are incorporated in the new cholera guideline. So there will be two presentations that roughly will be around 15 minutes. The first one that I will be sharing with you about the strategy, and the second one that Paul will be sharing about these updates. At the end, we will open it for questions. But throughout the presentation, you are more than welcome to write the comments, questions that you might have on the chat on the left side. So write them, we'll try to answer all of them at the end, but we will open that at the end, not before that. And then we will also open it a little bit for some feedback towards the end. We will share these presentations. So yes. So let's start. In fact, all of you should know this, this diagram, the F diagram for cholera transmission. But perhaps what we don't know always is which activities are blocking which different pathways of transmission of cholera. And definitely something that we like to see is what different actors that are responding to the same outbreak are doing and which are the path of transmissions that they are trying to block. So one thing that is very important when dealing with a response of cholera and trying to set up the strategy is to see that all the transmission pathways of cholera are being targeted. Okay, so I encourage you to always have this diagram in the back of your mind, but making this link about activities and the transmission routes and who is doing what in the different outbreaks. So in MSF, and when I'm talking MSF, I'm talking all the different sections of MSF, like the strategy of cholera prevention and control can be divided in 5 different pillars. So it's also called this strategy as the 5-tier strategy. It's a strategy that also even other actors know about how MSF responds. So it's crucially important that you all know which is the strategy. So first of all, we have the health facilities. Secondly, domestic setting and household. The third pillar is the ring strategy. The fourth is the high-risk groups and high-risk places, so hotspots. And then the fifth one is the setting of endemic settings with recurrent outbreaks. So I'm going to go one by one to try to explain what each of the different pillars entails. Sorry, I'm still not used to passing. So first of all, let's go to the health facilities. So the health facilities are the single most contagious point, the highest risk area that we can have within an outbreak. Thinking that we have in the cholera treatment centers, there's like a high possibility or high risk of infection between patients and the health providers, patients and accompanying family members or caregivers. And then as well, we have like the accumulation of all the patient's waste that is generated and has to be properly managed, disposed and treated, because otherwise can be released to the environment and as well make the outbreak even bigger. As well, we have people that transport patients in different means. So we need to make sure that around this health structure, the cholera treatment centers, the cholera treatment units, oral rehydration points, they are all being taken care. So we know that by default, MSF, what it tries to do, besides saving life, is not to harm. So in this means, WASH intervention is the one that prevents the staff, patients, people that transport the different patients and the visitors to prevent from transmission. So here the strategy is that we need to make sure that since early onset of the start of the outbreak, we have what's an expertise within our response inside of like the health structures. It can be built as CTC, it can be being built as CTU, or it can be just give the support that the Ministry of Health needs in order to make in place all this like infection and prevention and control within this health facility. And for doing that, you know that we have the new cholera guidelines as the main guide of the different activities that has to be implemented and the different standards that need to be implemented. Also for you to know that in MSF, we are currently doing operational research on how to improve our response within the health structures itself. So we are looking at different high concentration chlorine solutions for treating the waste, using hydrated lime for treating as well the vomits, and how we best can manage the cholera sludge that is being generated within a cholera treatment center. Okay, so now we go to the second tier, and the second tier goes into the domestic setting. So we said the cholera treatment centers, because we have all the sick people, is like a high risk area. So we have to manage our infection control within. But then the second point that is highly at risk is the household itself of a person that is being diagnosed with cholera. So someone that lives with this patient inside of the household is 100 times more at risk of being infected with cholera. In fact, cholera patients, despite that might be showing signs or not, they are highly infective for the first 7 to 10 days. So the fact of having this close human-to-human interaction, sharing water containers, sharing food, sharing utensils, the caring responsibilities that happen within the household are the main transmission routes and makes that the household, inside the household, is really like a hotspot of transmission. So this second block focuses on trying to reduce these transmissions, intra-household transmission. And the strategy here focus on the distribution of hygiene kits or disinfection kits within the household. So basically, the idea is that we have a fast intervention by distributing these kits at the cholera treatment center to the caregivers, and the caregivers are going to be the ones bringing the kit and implementing and using the kit at household level. So this should be a very fast activity. It's activity that is by default in any cholera outbreak response. We need to do this distribution, rapid distribution of disinfection kits to the caregivers of the patient itself. It also allows, no matter we are doing like an oral cholera vaccine, the oral cholera vaccine has a gap in which of like a week before it gets before it gets effective. So So the fact of distributing really fast these disinfection kits and putting them in practice cover this gap where the people are not really protected by anything, by just what is really important, all the sanitation and infection within their household itself. As well, the fact of distributing these kits helps to improve the health-seeking behavior of the patients, of possible patients. And because we are very targeted somehow, so then we aim to reduce the number of cases that are coming to the health facility. This strategy has been used since several years within the different sections and even within OGBA. For example, the first interventions distributing disinfection of hygiene kits was in Haiti in 2010, 2011, 2014 as well, and in Congo in 2017. And I do believe now at the level of like Ethiopia, South Sudan, and other countries, we have been, like Congo as well, we have been distributing disinfection kits. So what is the research that as the working group we are doing in these terms? We are on the side looking at the impact of using these disinfection kits. And then as well, how are we trying to do better the possible integration of distributing disinfection kits along with like the cholera vaccine. So here you can see an example, like a picture of what it is called the fake house. This house was built in this fake house was built in one of the CTCs in Haiti in 2014, where the patients, and well, not the patients, patients perhaps were too sick, but the caregivers of these patients would be informed how to use the disinfection kit that was distributed. How would you implement, how would you use it inside of your household to go to the key areas that you have to make sure that you clean, to make sure that the person understands how to treat the water inside of the household, how to place, in which places they have to put the hand washing station and so on. And by the way, you have like an example of a possible content of a kit. But we will refer at this a little bit more in Paul's presentation as well, so the idea might be clear. Then, when the first pillar being the hospital or the health facility, the cholera treatment unit, the cholera treatment center, the second one being the household and the distribution of these disinfection kits, and the third one being what we call the ring strategy or CATI approach, case area targeted intervention. And what that means is that not only the people that are inside of a household are 100 times more at risk of being infected by cholera because they have someone that was infected in that household, but the households that are all around this household are much more at risk than households that are further away. So research shows that if you live within 50 meters of a household that has cholera, you're 30 times more at risk than someone else that lives farther. And this risk decreases with distance, but it maintains quite a bit with time for at least 3 weeks after the person has been diagnosed. So looking at these risk areas, this is where it comes, the strategy of approaching the distribution of kits at like a ring level. So let's go to this little animation. We have the CTC, the CTU, or an oral rehydration point. So then we have our health promoter that has a disinfection kit that gives to a caregiver that just arrived to the health facility. Then our health promoter goes to the household of the patient to make sure that the persons within that household are using properly the disinfection kit, despite that there might still, that their other beloved one is still in the hospital. Then, like the community health workers, look around to the households that are in a radius and in proximity to this main household where we have cholera patient. So then it's up to us, but like normally, like the literature advice and what we advise is from 50 to 100 meters, the households that are in line should be targeted. So then within these households, there's also a promotion, a visit from the community health workers, and a distribution of the disinfection kit, and a promotion of how to use it as being the people that are highest risk of being infected by cholera. So now we go to the fourth pillar. So the previous two pillars, in a way, they are working in a sequential way. But now we go back to a main pillar that is not a sequential one of the other ones, but should be really looked as in parallel as from the starting of the intervention. So is to try to focus to the high-risk groups and high-risk places. So what is also essential, and this is context-specific, is to have a rapid experience and ideally multidisciplinary evaluation to identify in each context which are the dominant transmission routes and the high risks and high groups and high risk places. For example, I don't think it's new if I say that a high transmission could be the funeral practices, for example, in places like Congo or places like in the Sahel. So this has to be really looked because context-specific win-win intervention should be put as soon as possibly once we know which are these main transmission routes and which are the groups and places that are more at risk. For example, as well, the proximity to water sources like the Lake Kivu, in like the outbreak in Bujumbura, or like the outbreaks that we have in Bukavu, should be looked upon as might be one of the main transmission routes of an epidemic. It can be as well the fishermen and boatmen that are the carriers of of cholera. Or it could be the fact of having a very intermittent and broken water distribution system that supplies water and eventually mixed with some of the sewage system. So all this has to be analyzed from the beginning of an intervention, and measure has to be put in place right away. And then finally, the last pillar that perhaps in MSF OGBA we haven't been that much involved with, but other sections are, is the setting in which we are in places with recurrent outbreaks. And then the approach is really into going to a structural activities, long-term activities on the side of the current governments in order to structurally improve all the water distribution networks, improve all the waste sewage networks, put in place big promotion campaigns, and so on. So, in a very fast nutshell, I just went over these 5 tiers of the strategy that MSF is putting in place in different settings, in different places, in order to do Watson cholera prevention and control. So we have, again, health facilities that are in sequential activities with the distribution of disinfection kits towards the households with the second tier, and then the ring approach from the household itself of the person that is sick with this sequential, and then we have the fourth tier with these context-specific, quick win-win activities, Watson activities to the high-risk groups and high-risk places, and finally, interventions more long-term in places where we have the money and the time to improve all their water and sewage networks. So for this first part, the main conclusions are that the initial Watson response is a lot of it context independent. The fact of like setting up CTCs, flow, infection control flows inside, and like the disinfection kits are really context independent. But as soon as possible, we need to start looking into the high risk and high growth places and understand and contextualize the response as well. And it's important to differentiate a little bit these long-term interventions for what it is, like a more emergency intervention as we normally do. And then emergency preparedness is key. It's not only key to do a proper Watson interventions, but to make sure that we can go hand with hand whenever there might be an oral cholera vaccine distribution as well, linked with the response of cholera.